Okay, so now we talked about dysrhythmias early in the semester. We have our sinus rhythms, which have normal intervals. So the PR interval is always going to be 0.12 to 0.20 seconds or 2 seconds. QRS is going to be narrow. The ST is going to be isoelectric. Don't even worry about STs. I wouldn't even put that on an exam. Um, and then with first degree block, okay, the PR interval is prolonged, but everything else like sinus rhythms is normal. Okay, so on ATI, they did have a rhythm strip with a first degree block on the proctor, and the answer was the P is far from the QRS. Okay, and usually, sometimes they have questions about hypokalemia and hyperkalemia with first degree block. The causes of first degree block include medications, being an athlete, elevated potassium or low potassium. Okay, so that's important. Don't remember, okay, sinus tach means your body's under stress. It could be good stress like you're exercising, or it could be bad stress. Anytime somebody has sinus tachycardia, you need to investigate because you need to fix what's causing it because that's how you stop tachycardia. So you don't need to like really memorize any of this. Same with bradycardia. So find out what's causing it. It could be fine. If they're asymptomatic, don't do anything about it. If they're symptomatic, they're going to get atropine. If that doesn't work, they'll try another pressor. If that doesn't work, they'll do a pacemaker. Okay, with atrial dysrhythmias, atrial fibrillation is the most clinically significant dysrhythmia in this country. Like anything that causes stress can cause AFib, so I wouldn't even like memorize this, okay? Um, the PR interval is not going to be measurable. Remember, it's going to be irregular. The assessment finding that ATI loves to use is they have a pulse deficit. All right. So if somebody has AFib, you cannot cardiovert if it's been going on longer than 48 hours. They're going to need a TEE before that. Okay. Um, with A flutter has the regular sawtooth waves, and this has been proctor topic before, and they were asking about the sawtooth waves. So nothing too drastic, but you just have to remember that A flutter is the one with sawtooth waves. Okay, so SVT. So with SVT, this is going to be a fast, greater than 150. Okay, fast, regular rhythm. Patient comes in, they're stable, just have them vagal, see if that works. If that doesn't work and they become unstable, they're going to need cardioversion. If they are not unstable, they can get adenosine. Okay, if somebody's having a lot of PVCs or trigeminy, check their potassium. It's always going to be about potassium. Okay, if somebody has complete heart block, and that's the way I think they describe it in ATI, because this has been a proctor topic before, complete AV heart block or third degree heart block. Remember, we have to do the transcutaneous until a permanent can be placed. So you're going to put that, just look for more P waves than QRSs in a slow rate. All right, VTAC, check the LOC and vital signs. If they don't have a pulse, you're going to defibrillate. If they have a pulse and they're stable, call the provider. Pulse and unstable, give them synchronized cardioversion. With VFib, it's going to be, you want a defib. This is ST elevation. And okay, so this is somebody that is paced, and this is ventricularly paced. And how I know that is if you see this pacing spike right here, and then you see a QRS. So that means the ventricle is paced. So we got a pace QRS here. And they're always wide, paced ones. We got a pace QRS here. We got a pace QRS here. But what's going on here? This is called failure to capture. Okay, so you need to check the LOC and vitals. This has also been a proctor topic before, and they were asking like which chamber is paced. So if this spike comes before the P wave, that means the atria is being paced. If it comes before the ventricle, before the QRS, it means the ventricle is being paced. So if you have a situation where it's failing to capture, okay, assess your patient, check the LOC and vitals. Okay. The two rhythms that are shockable are VTAC without a pulse and VFib. Synchronized cardioversion is for tachydysrhythmias that are unstable. Okay. AFib, a flutter with rapid ventricular response. Remember, you have to get the TEE. So cardioversion, how does it differ? You have to synchronize it in the timing and energy. So there's more joules with defib. And I would never expect you to know the different joules between each rhythm. So describe how an RM would complete an initial focus assessment. All right, so I used to give students questions, but I'm just going to tell you the answers. So with the cardiovascular assessment or any assessment, right? And you need to do a focused assessment, you're just focusing on that symptom. You're not asking them about every disease they had in childhood and their past medical history, okay, and their meds. Okay, you just want to do the assessment. So with a neuro assessment, remember, see if they're A and O, see their pupils react. Okay, so you want to check all those things. Okay, so with cardioversion, remember, ensure the defibrillator is in the sync mode. Hold digoxin for 48 hours beforehand because the patient go into VFib if you don't, and no oxygen during shock. For defibrillation, this is the priority in VFib and VTAC with no pulse. No sedation, don't sedate, you cannot wait because they need to be defibbed. Okay, so remember you're coached. CPR should be in progress while you wait for the defibrillator to fire up. You're going to make sure the oxygen is off anytime you deliver a shock. All others away means you make sure you call out all clear 3 times. You're going to charge the defibrillator. While you're charging, people are still doing CPR. Call hands off for everyone. Evaluate the rhythm and defib. Okay. Both of these, you have to apply the defibrillator pads, call out and look all clear. So that's important for safety. Okay, with cardiovascular meds, okay, remember the difference between selective beta blockers and non-selective. So selective are A through M, and non-selective are N through Z. We don't dilute IV beta blockers before administering, okay? And so if you have a cardioselective beta blocker, you don't need to worry about bronchoconstriction. Make sure you monitor glucose levels closely if somebody's on a beta blocker because they're not going to have like the tachycardia and diaphoresis. Monitor heart blocks and bradycardias and never stop abruptly. Okay. And then with patient teaching, report a new cough tell them to report a new cough at night because that could be a sign of CHF. Beta blockers are negative inotropics, meaning it makes the heart like relax a little bit more. They may cause erectile dysfunction. That's why men stop taking them without telling anybody. And then tell them to rise slowly. Okay, for ACE inhibitors, patients shouldn't be using salt substitutes, especially if they have kidney disease, because that's going to increase the potassium. Explain to report lightheadedness, and then monitor for like tongue swelling. Okay, and then for heart failure and pulmonary edema, so they need to report a weight gain of greater than 2 pounds in 24 hours or 5 pounds in a week. They need to be on a low sodium diet and fluid restriction, daily weights, and report swelling of the ankles or shortness of breath. Patient teaching with furosemide, I think you know, tell them to eat foods high in potassium like bananas. monitor for low magnesium, low potassium as well, and then monitor the provider for if they have like ringing in their ears. And then especially if they're on other medications like gentamicin or something like that, you worry about deafness. All right, let me see what med this is over here. Oh, this is statins. So no grapefruit juice with statins, and warn them about photosensitivity. Okay. With ABGs, okay, so I know you had these in MedSurg 1, okay, but make sure you remember how to read them. And so if somebody has respiratory acidosis, okay, and they have a normal PaO2, the treatment is not oxygen, okay? The treatment is going to be getting them to turn, cough, deep, breathe. They have to blow off that CO2, okay? So early ambulation and centrospirometer. All right, and then with respiratory alkalosis, okay, somebody like is really anxious and they start hyperventilating, then get respiratory alkalosis, you're going to have them breathe into a paper bag. And somebody who has hypoxemia, okay, so their PaO2 is low, you're going to put them on 100% non-rebreather, and they may need PEEP. So they would do that for hypoxemia. All right, so nitrates. Okay, so nitrates. Now, what students often forget is that long-acting nitroglycerin nitrates are also have the same implications, right? Like isosorbide, dinitrate, or mononitrate. It's prescribed, take it daily, PO on an empty stomach. Okay, patients cannot take sildenafil or anything for erectile dysfunction if they're on those medications. Okay, tell the patient to rise slowly. If they're taking nitroglycerin, it has to be kept in that vial it comes in. And they can, if they're taking nitroglycerin and they need it, if they get no relief after the first one, they have to call 911, and then they can repeat, and then they can do a total of 3. All right. They may have a headache. Too bad, so sad. Just tell them it'll go away, and they can take acetaminophen, rise slowly, and then report dizziness. Dizziness is not expected, so they need to report that. And monitor their blood pressure. Okay, so the medications, and you already know this, we had this on the last exam, that can cause high potassium. The ones that we focus on in this semester are ACE inhibitors, ARDS, and potassium-sparing diabetics. So if a patient has like a high potassium, the ECG changes you're looking for is that widened QRS, ST depression, don't worry about that, peak T waves, and prolonged PR interval, so a first-degree block. Okay, this is important with respiratory, okay? Now you're going to have to know the difference between the alarms, and we always keep our alarms on. Alarms on is very important. Okay, high alarm, if they're vented, means obstruction. So you're going to look for like the secretions. Maybe the client's biting the tube, maybe you need to medicate them. Maybe they have edema or a pneumothorax. So it just means that there's some kind of obstruction going on. If the low alarm is going off, that means it's displaced. And this is a danger because your patient may not be breathing if this goes off. So it means it's easy to push air in. Okay, so high alarm, non-vented, fast respiratory rate. So you're worried about increased work of breathing. If they're in the unit, you would worry about ARDS. And then lower alarm, check medications, or it's somebody that has low respiratory rate, they may still be breathing okay. Okay, so you would go check them. But if they're on a vent and they have a low alarm, assume they're not breathing and you need to get in there right away. All right. Nursing intubations to prevent BAP. Make sure the head of bed is 30 because you don't want them aspirating because that's how they get BAP. Mouth care and GI prophylaxis. PEEP. Okay, this has been a proctor topic before. So what's the therapeutic effect of PEEP? PEEP allows us to oxygenate people with less oxygen, with less FiO2. Okay, it stands for positive end expiration pressure, and it keeps alveoli open, so we can oxygenate patients with less FiO2. So it helps with better gas exchange. The risk factors for pulmonary embolism. Okay, you have to know these. Now, students always get worried about a patient that's immobile. Now, remember, somebody that's immobile has to be immobile like 3 to 4 days before they're going to be developing a DVT. Okay, so trauma is probably the highest risk. Okay, people that are taking estrogen, people that have leading 5, you don't have to worry about that, but we had somebody in the hospital when I did clinical, and that's like a clotting disease. Older people, people with malignancies, especially latent malignancies, some people present with DVT, and you're like, what in the world? And then you find out they have a malignancy. Long bone fractures, they're prone to fat emboli. Fat emboli, remember, patient develops a petechial rash with that. And then orthopedic surgery, hip arthroplasty has the highest incidence of DVT out of all the surgeries. People that smoke, people that are immobilized 4 to 5 days, and people like with nephrotic syndrome, okay, sickness. The signs and symptoms, expect immediate shortness of breath, cough, and they'll have a low grade fever, and then they're going to have those feelings of impending doom. They could have shock like vital signs as well. All right, your ABGs early are going to show respiratory alkalosis. Okay, so the signs and symptoms of a pneumothorax and a tension. So this could occur like if you're doing insertions, helping the provider, like pacemaker or central line, um, portacap. That they can happen with any of these kind of conditions that they're doing. It could occur when a patient has high PEEP because it can like essentially blow out the lung if the PEEP gets really high. So your signs and symptoms are going to be a pleuritic chest pain. Usually they complain about breathing in, it really hurts. JVD, tracheal deviation if they have a tension pneumothorax. Hyperresonance, don't worry about that. The onset is sudden. Reduced breath sounds and dyspnea. Don't worry about absent fremitus, and vital signs are going to be shock-like. Okay. With the chest tubes, okay, you got to know where the bubble should be, and where the bubble should not be. The bubble should not be in the water sealed chamber because that means there's an air leak. Now, if somebody has a pneumothorax, you should see an occasional intermittent bubble, but you should never see constant bubbling in the water sealed chamber. You will see constant gentle bubbling in the suction controlled chamber, which is this one right here. Okay, this is the one we fill up with water to -20. Okay, so this gets hooked up to a wall suction, and you do it until this is gently bubbling. All right. So your interventions, you want to report drainage more than 70 and monitor the color and consistency. With the water seal, you report an air leak if it's not expected. And then with the suction control chamber, you want to make sure that there's gentle bubbling. With the water seal, okay, remember this is the where you're going to see the oscillating when the patient breathes. It'll go up and down, okay, when they're breathing. When the pneumothorax heals, they'll no longer have titling. If they've kinked it off, they will no longer have titling. So you have to kind of look for that if you don't see any titling, see what's causing it. Your nursing implications for suctioning, very important fundamental topic. So students that work in home health are often confused because deep suctioning is a sterile procedure. Okay, so if you're suctioning somebody's trach or an ET tube, that has to be sterile, okay? So hyperoxygenate with 100% FiO2. Make sure you're applying the suction on the way out. You're holding your thumb over the suction. Twirl when you withdraw, and no longer than 10 to 15 seconds, and only 1 to 2 quick passes. Okay, you can put the suction on the wall up to 150 millimeters of mercury only. Okay, that's to prevent damage, and lung sounds before and after to evaluate how the suctioning went. Okay, and encourage the patient to cough before suctioning, as long as they don't have increased intracranial pressure. All right, ARDS. These are the people that are prone to ARDS, or the causes of ARDS. Okay, so it's like aspiration, sepsis, heroin overdose, inhalation injury, because we did burns. People with burns are very prone to ARDS, not only if they had an inhalation injury but they're prone to it because it's massive trauma and they have leaky capillaries, so they're going to be prone to it. Pancreatitis, trauma, hypovolemia, and uremia. Hypovolemia happens early in burns, so you have to prevent that. So prevent it by maintaining proper fluid balance, preventing sepsis. Atrial is a transfusion reaction that happens like 6 hours after they get infused. The treatment is going to be mechanical ventilation with PEEP, so it's like your 6 Ps. PEEP greater than 5, because remember, 5 centimeters of water is what everybody has, the PEEP everybody has in their lungs. So if it's higher than that, you know that they probably have ARDS. Paralysis, meaning we're going to paralyze people so that we can let the vent do the work it needs to do. Give them protein, so that means early enteral feedings. Put them prone, because that's going to take like the heart and the great vessels off their lungs so they can expand better and improve oxygenation. It's also called non-cardiac pulmonary edema, so expect a normal CVP and wedge. Okay, I like this mnemonic the best. I think it will help you the best. Okay, some more memories. Okay, so we talked about, students usually do awesome on this. Military triage, just read through each type and know who's going to get what tag, okay? And then the nursing implications for blood transfusions, the priority assessment for hanging blood, okay? So the first thing you got to, check that the client signed the informed consent. You're going to make sure they have a 20 gauge IV. Assess the vital signs, urine output, and skin color, okay? Assess for a history of transfusion reactions, and administer blood with normal saline, and check blood with another licensed nurse, and you must stay with the patient for the first 15 minutes. Most transfusion reactions happen like with 10 mLs going in. Now, okay, so the reason you're checking the vital signs, obviously, you want a baseline temperature, right, in case they have a febrile reaction, but the urine output, you want to make sure they're putting out urine before you put blood in. Blood is very viscous, and you don't want them to have fluid overload. And check their skin color, because if they have an allergic reaction and they have like urticaria, you can kind of compare. So that's red blood cells. Platelets. Now, if you have to give somebody platelets, okay, meaning they have a low platelet level, you want to get the most bang for your buck. You're going to give it, if you're giving it for a procedure, you're going to give it right at the time of the procedure, okay? You want to give it at that time because they're going to probably be destroyed as soon as you give them. So you want to get more bang for your buck. Okay, this is comparing and contrasting cholecystitis and pancreatitis, okay? I'm going to go over pancreatitis. Remember, the two most common causes are ETOH and biliary obstruction. So the cage assessment from psych. You might have to do that. But With pancreatitis, the pain is going to be in the left upper quadrant with radiation to the back. You're going to keep them NPO to keep the pain down, but also not to make the condition more severe. The patient is going to be in more pain lying supine, so you can encourage them to get in the fetal position or sitting upright and leaning forward. Remember, gray Turner sign is graying of the flanks. Cullen sign is discoloration in the umbilical area. Okay, so your priorities when you're assessing is going to be your lung sounds because they're going to be prone to ARDS. So you're going to monitor hypoxemia. They're also prone for pleural effusion, so you got to monitor your lung sounds. They're also going in the C category. They're going to be prone to DIC and hemorrhage, and they may become encephaloptic. Okay, so monitor their temp. No ETOH, no caffeine. They need to eat low fat, high protein, and minimize spice in the diet. Complications, just talked about that. Enteral feedings. Okay, if somebody needs like early enteral feedings, you check their bowel sounds, but really having hypoactive or no bowel sounds, they'll probably still do it. Head of bed needs to be 30, 45 is even better if they can tolerate that. Sitting up in a chair is the best. Assess the marking at the nares or the abdomen and check residual in return unless it's excessive. So if it is like really close to the amount you're giving, you're going to have to hold it. But if it's a low residual, just put it back in and go on with your feeding. All right, low perfusion. I think I probably have really hit you over the head with this. So I think you'll be able to pick out conditions with low perfusion. Okay, now the symptoms of an MI. Okay, I think you know about the chest pain that doesn't stop with change of position and respirations, right? But let's talk about some atypical signs. So sometimes people have GI distress or indigestion, and that could mean they're having a heart attack. Women can complain of like toothaches or extreme fatigue or jaw pain. So these would be atypical presentations. Okay, so the pain is described as heavy, tight burning for people that have the more typical presentation. Usually, MIs occur in the morning or during sleep or rest. And it lasts 20 minutes to 30 minutes or longer, and it's only relieved by opioids. You expect, I'm going down to this question here, when is a pulse deficit expected, AFib and PVCs? The position for hypodynamic shock is supine with the legs elevated, not Trendelenburg. Really, the only thing you would use Trendelenburg is if it's an air embolus. Okay, in cardiogenic and obstructive shock, sit upright. So remember the signs and symptoms of the different kinds of shock. Cardiogenic is going to present, it's like cardiogenic, I think of as like severe heart failure. Okay, so they're going to be confused. They'll have shock like signs. They'll have a high wedge CVP and poor peripheral pulses. Okay, with hypovolemia, they're going to be confused. They'll be dizzy in the bed and they haven't been drinking. Remember, in shock, the pulse pressure goes narrow, and they'll have an increased respiratory rate and low urinary output. With neurogenic shock, remember that they're the ones that have the low heart rate, low blood pressure. Okay, their skin is going to be warm and flushed. Okay, so on your proctor, you're going to have questions about brachytherapy and teletherapy. Brachytherapy is implant therapy. Okay, and I don't know what the question is, but I have not cracked that code. But with Brachytherapy, like if it's a season implant or something, don't let your patient get constipated. They're going to be in a private room. Make sure they're on bed rest, have a Foley. Um, and if it comes dislodged, you pick it up with forceps and put it in a lead container. Somebody going to bed? All right. So with ototoxic meds, this is often also a proctor topic. So this is important. Ototoxic meds include aspirin, NSAIDs, aminoglycosides, platinum medications like cisplatin, like oncology medications, chemotherapy, and loop diuretics. Now, ethacrynic acid is a loop diuretic, and it's often used if patients are allergic to sulfa instead of giving furosemide, because people that are allergic to sulfur can have sensitivity to furosemide as well.
That recipe was an experiment, and it did not turn out well. But I do want to show off my new wooden spoons. I got these.
Who's got their
Convention Center in Biloxi. I mean, look how beautiful that is. I did not catch his name, and it's not on this card, but here's
all right, how do I turn that off?
This don't always turn out right, sis. What are you gonna do? I'm about to make an apple pie, so let's see if we can do that without it up, and I'll post that this weekend.
I think an apple pie.
I think it's Holly. Holly, who is it? Okay, somebody turned it off. Okay, thank you. So those are some of our memories from our class. Does anybody have any questions about any of that?